Well, hello. Always a pleasure to be presenting in front of all of you. Also a pleasure to always be up here with Bob. So, last summit we were asked to do something together, and so we tried to brainstorm on something that you all haven't heard from us, right? Something new. And so we decided, let's do something on resorptive lesions. Okay, we're not endodontists, but we thought this would be great. We'll learn ourselves into it, and we went to the literature thinking that this would be easy, and it was extremely challenging because there's no consensus in the literature on resorptive lesions. So we power through it, and then we end up now a year later.
Yeah, and so Gregg put that challenge up for us, and so we planned these well in a year in advance, and so we decided we'd do something together again. So I guess it was my turn to pick a topic, and I said, hey Gregg, one thing that's always interesting to audiences talking about failures, right? Failure festival. And so I thought, hey, let's do that. And Gregg said, okay, we'll do that. We'll talk about failures. And we came up with a title, and then time starts running. And of course, it's always in the back of my mind, and I'm sure it was in the back of Gregg's mind. But then I started realizing that, Gregg, I don't have any failures, so we're gonna have to use all your cases.
So we have an inherent problem. We're going to be done really early because I didn't have any either. So then we thought, we can't do that, right? We're supposed to be up here an hour. So Frank's got a ton of failures.
Yeah.
We could use Frank's failures.
Yeah, we use those in the workshop, so.
You've all seen them, so we can't do that. So now we really have a problem. So I want to thank everybody when we send out our mass email. Thank you for all the cases you sent us. So we'll be using those today.
Yeah. So we won't call out any names, but thanks for sharing all that with us.
No, the reality is we all have failures, whether we call them failures or complications. And oftentimes we look like this person sitting on the dock when they occur, right? It happens to all of us. The question is, how do you respond to it? So that's what we'd like to do for the next hour.
Yeah, and that'll be interesting for us to begin to think about a definition of failure. You know, none of us really wants to fail or consider ourselves failures, right? So if you begin to look into the definition of failure, right, it's interesting to think about how we analyze that, and we look at the terminology that would be used. It's, of course, lack of success. It's the negligent or omission of an expected or required action. So that's a pretty good definition of failure. So we don't want to fail, but then we start looking at each other and say, are we really failing, or what's the real issue here?
If you think about what we do in dentistry, nothing we do lasts forever. So can we really call it a failure if it's an anticipated lifespan for what we do? Or is it maybe just a complication? And so if we now look at the definition of complication, it actually almost seems more fitting, right? It's something that changes the course of action, changes the course of your treatment. What you thought would happen didn't happen, and now you have to do something differently. And so it'd be nice, I would always like to say that I encountered a complication much more than I would like to say I encountered a failure. But as we started to think about it more, I think in dentistry we have both. And oftentimes it's a gray area about actually which one is occurring. And I think it's unique to dentistry that we confuse a complication versus a failure, because that doesn't actually occur in other parts of the world. So what's a true failure outside of dentistry? Well, I'll show you one. This is the Tacoma Narrows Bridge. It connects Tacoma proper to Gig Harbor. This is the bridge that was built. It was built back in the 1940s. It took 2 years to make. So it was actually opened on July 1st, 1940. Now, at the time where they were fabricating this bridge, they started to know that it had some movement issues. That in the fabrication process, it started to bounce with the wind. In fact, it had a name. They called it Galloping Gertie. People would come from all over to see this moving bridge. So they know during the process of fabrication that it has issues, and they tried to get it closed down, shut the project down, but it continued, it passed through. And it actually opened. Now you look at that and go, that's incredible. I'm amazed that those materials are able to do that. That's concrete and steel, and it's flexing. Well, then the wind came up. So now we're 4 months later, 40-mile-an-hour winds, and all of a sudden, you start to have a little bit more action in the bridge. Right now, I think that's a success that it actually hasn't imploded upon itself. 4 months. 4 months after it was made, it broke. Catastrophic failure. Now that's a failure, right? We can all agree on that. In dentistry, though, it's a little more challenging to decide, is it a complication or is it a failure? So in order to help us kind of think through the process, what Bob and I have decided to do was, let's make a decision tree. That'll start to get us to think all on the same page, because we at Spear like decision trees. It actually helps us communicate. So it has to start with, we're trying to figure out, is it a failure or is it a complication? So let's say you have a problem that occurs.
So the key first is identifying the problem, and you may identify it, but usually it's the patient identifying it first. And if we try to categorize this for you, we're looking at patients in general, and some of our patients we treat, we know we can do virtually anything to them, and we will be successful long term. Other patients we look at, we know that we would be considering them high risk. You know, maybe they've destroyed their own dentition, wearing them out. And I might say to a patient, well, if you've done that to your own teeth, you may want to destroy the restorations I make. It could be also a procedure or a material that we look at as high risk for the situation. And the key in this is identifying those elements, right? So if I do an informed consent, and if I realize that I have a high-risk situation, either patient, procedure, material, and if I inform the patient about that, right, and then something occurs, an event or problem occurs, then we would consider that a complication because we anticipated what was going to happen. But if we didn't talk to the patient about our concerns and make them aware of the situation, we didn't fully inform them, so it wasn't informed consent, then we've decided to call that a failure. It's a failure on our behalf for not disclosing maybe something we knew. So that would be a high-risk situation, whether it's a patient, procedure, material that we choose to use.
So that brings up the question about when you're doing dentistry, do you assume risk, right? Do you treat risky patients, or do you do materials or techniques that might be construed as risky? And the reality is, as Bob and I kind of talked about this, I think we're both calculated risk takers. If I'm going to take a risk on a material or a technique, if it fails or has a complication, I want to know what it's going to be, and I want to know that I can recover like I never had the problem. But if you look at this quote from Elon Musk, I think it's actually interesting. If you're not failing, you're not innovating enough, right? He's a brilliant mind. So then I look at Frank, and I think Frank is a wonderful innovator. And I say that only in the best way, because he had a lot of failures. Now, I shouldn't have as many failures as he did, because if I did, then I'm just not learning from what he's learned. But I also don't like to take risk. I don't try to take risk. It's calculated risk. But you have to now think about how that works in your practice. So now let's say you have a normal patient. It's not a high-risk patient. You're not doing a high-risk procedure. And now you have something that occurs that is unanticipated. The question is, who has a problem with it? Maybe it's you and the patient, right? That's probably the most common. They have a problem and you concur that it's truly a problem. Now, the question becomes, when did the problem occur? This is the gray area we have in dentistry. Putting a time limit on what you do. And what we refer to is we oftentimes refer to insurance companies using a 5-year mark. But the problem is insurance companies don't really know. Because insurance companies, they don't have data to see how long things actually last. Because imagine this, let's say you're an insurance providing dentist and you have a failure and it occurs before the 5-year mark. You're not going to resubmit it to the insurance company because you're not going to get paid. So you just do it and you eat the cost. So all that knowledge about when things fail, we don't know. In fact, the literature, we were surprised of how little information in the literature there is that we can actually use. Because the literature is dated.
Yeah, and one of the problems when you do look at the literature, and the important thing to consider is short term is considered 1 to 5 years, medium term is 5 to 10 years, long term is 10 plus years. So in reality, if we want our restorations, our treatments, whatever we do to last long term, we should have 10 years of research before we do our procedures, use our materials and so forth. And of course, we don't have that. So we are being put at risk because we don't have that information. But then we have to go retrospectively and look at it and decide, again, where we're going to take a risk or not and which procedures or what materials to use.
So we don't have much to go off of. We'll use the 5-year mark because that's kind of the only thing out there. If it fails less than 5 years, we're going to consider that as a failure. Didn't anticipate that happening. If it fails after it's been in the mouth 5 years, different story. Because, again, the insurance company would say, we'll pay you again to do it, which means that it maybe wasn't supposed to last any longer than 5 years. Now, what if the patient comes in and says it's a problem, but you and I as clinicians look at it and go, I think you're okay. Now you have a problem. Because now you have to manage the patient and you have to manage the problem. And sometimes managing the patient is actually more challenging. So when we have a patient that comes in and has a problem, what we'll actually look at is, where is the problem? Is it an aesthetic, functional, structure, or a biologic problem? Because we think that you can actually have failures in each of these 4 categories, which is kind of convenient, right? This is what we teach every day. So it makes sense that if we're addressing these areas, we can have problems that occur in these areas.
So when it comes from the aesthetic side of things, and we'll look at a number of cases in each category, and you'll identify that many of the problems or consequences may be overlapping in different categories, but you may look at this patient and you say pre-treatment, it's a no-brainer. I can make pretty teeth for that patient because she's desiring a more beautiful smile. But the question is, can you, right? If I then look at function, you may have muscle issues, muscle discomfort, temporomandibular joint issues, but you may have, I'll say, more of the simple type things as occlusal design issues, and that may impact other things such as structure.
I think dentists, restorative dentists in particular, are most familiar with structural problems, right? Things breaking. And it's interesting, as we talked about failures of materials, intuitively, if you're a restorative dentist, you're going to do this. It's not my problem. It's the lab's problem, right? They didn't design it well. They used the material that I didn't want. It's their issue. But when we start thinking about structural failures, it's easy to pinpoint that it's a bad material. The reality is we actually struggled trying to find material problems. The problem's actually with the dentist. We choose materials improperly. We mishandle materials. We don't give room that we need. So you could almost say that most material problems are actually dentist caused. It's not a material issue. Either you picked the wrong one or you didn't manage the situation correctly. Which then brings up the idea that, you know what, the best dentistry is no dentistry, less dentistry. So you want to start minimizing structural failures, then treat or treatment plan differently. Because if we can stay in the composite realm and we have failures in the composite realm, it's much easier to fix, and the costs are easier to fix. Biologic issues are almost cut and dry with failure, right? So if you're a surgeon or you're doing surgery, you incur some risks. And some of those risks can be technique issues. Some of those risks can be pushing the envelope, and some of them can just be a patient who doesn't heal very well. But all of a sudden, the risk factors go up, and the results of the problem can sometimes be catastrophic. And then that brings in the last piece that you heard a lot about from Becca, airway, right? And you're hearing more about it from us because Jeff Rouse now has joined us. And we believe that this is now a very important piece in what we do, and it actually comes before the treatment planning process. And what's interesting is if you listen to a lot of airway people, they say that, you know what, occlusion's not as important as we thought it was, because a lot of the problems and movement patterns and causing things to break, it's actually an airway problem, not so much an occlusal problem. And I think it's easy to fall into that trap, but the reality is occlusion is still important. How the teeth touch, when the teeth touch, what the contacts that the teeth are touching look like makes sense still. In fact, if you can't manage the airway or the patient chooses to put restrictions upon you, then the occlusion actually becomes even that much more important.
So you only know what you know, and the key is to open your eyes to new things. And so we'll discuss treatment of patients that we treated them on the classic way, and we treated them based on what we knew at the time. But if there then is a complication or failure, then how do you adjust courses based on your current knowledge? And so we'll use, again, this particular patient a little bit later on how to transition to looking at airway as an influence in treating the patient differently today. But when I had the opportunity to do that, I'll talk about how I had to struggle with dealing with the patient and informing the patient and denial of treatment, because that's one of the consequences of informed consent. We always recommend you treatment plan everyone ideally, but I would argue how many of your patients follow through with your exact thought process and the exact procedures and so forth. Many times there's a bit of a compromised approach, but that's where I go back to informed consent, making them aware of it, and if they choose not to go an ideal, then there can be consequences if they don't follow through with a recommended treatment.
So here we are. We have problems that can occur in these 4 different categories of treatment planning. And the reality now is we have to decide, is it a failure or is it a complication? Because that actually helps us talk to patients, and it helps decide who's going to pay to redo it.
So aesthetics can be one of the most challenging areas to deal with because it's very subjective, right? There's no objective criteria what's aesthetically correct. And last year, I've had the opportunity to share with you my thoughts on body dysmorphic disorder. And those type of patients, you have to figure out who you're dealing with. And if you identify that there is a true psychological problem and you choose to treat the patient and don't succeed, I would argue that that's a complication. The problem is if you don't recognize the problem, so we don't see it and we get into the treatment, we would argue maybe, and we're not saying failure, now we're saying it's the dentist's fault for getting into treatment, because there's no way you'll succeed in that treatment.
Another aesthetic problem can be an unmet expectation, right? Now that's different than an outcome that's ugly. It's an unmet expectation. We know that we've never done something ideal. We've never done an ideal restoration. And especially with implants, if you can't achieve something that's ideal and you don't communicate with that with the patient, then shame on you. Because if they think it's going to be here, but I know the reality of it, it's going to be somewhere below that, then it's our issue. Right? So we have some onus in the aesthetic realm.
And so next is actually delivering what you say you can deliver. So if you set an expectation for the patient, and let's say you have confidence you may be able to do that, and yet you underperform in the procedure, or maybe the lab doesn't perform up to the expectations that you have, then you have a problem, right? So you look at that, and you would have to say that if you don't deliver what you're expecting and what you share with the patient, we would say that's a failure. And it's easy to blame someone else, but we always say you have to look at yourself first, honestly, and analyze that before you try and pass the buck. As Gregg already said, we want to blame material if it breaks. Well, it's not the material. It's how we're using it, how we're designing things, and that's why it may fail or may be called a compromise, depending on when that occurs.
Yeah, so what we say in the workshop says, you can do what we do. You can show what we show. You just have to pay a lab technician that's able to achieve the aesthetics that we're doing. So if you can't get the result that the patient wants, then the lab now, it's not the lab's fault. You got to just pick a different lab that can achieve that result. All right, functionally. Functionally, we have problems as well. Maybe you designed the occlusion incorrectly. And what this will show up as, it'll show up in a few different realms. It can have pain of muscles, pain of joints, it can have phonetic issues, and it can result in fracture. But again, fracture caused by an occlusal design issue, not a material issue. So when these occurs, design flaws, we're going to call those failures as well.
So then going back to, is it expected or not? And the complication is patient response. So we can't necessarily predict some patients' responses, although based on clinical experiences, oftentimes we can. So if we expect a certain thing, then we would call it a complication, right? So we expect it, we'll inform the patient about it, it's a complication, even though that may mean fractured porcelain, right? But we would classify that as a complication. But the unknown aspect of it confuses the issue for us, and the patient's response sometimes may not be known and may not be predicted, but I think we have a lot of knowledge and maybe we just don't want to admit it, and if we don't admit it, maybe we call that a failure.
So restoratively, structure, we have a lot of failures in structure. But you have to divide them now into two different categories. You can have materials that fail, or the tooth itself can fail. So from a tooth problem, you have to ask yourself, back in the risk category, is it a normal tooth or is it a high-risk tooth? Is it an endodontically treated tooth? Do you have a huge post in it? Do you have a small amount of ferrule? If you have a normal tooth and you have a problem with the tooth, then I'm going to say that's probably a failure. It was an unanticipated result. If you have a high-risk tooth, because we all restore high-risk teeth, my question would be, did you inform the patient of the risk? If I know that this tooth is a higher incidence of having a problem, I need to tell that to the patient. So we're both on the same page. Because if I communicate it and the problem occurs, I look like a genius and it's just a complication. But if I don't and it's news to them because I didn't inform them, then actually I'm going to call that a failure.
And we've already touched on the material aspects of it. We'd like to blame the material for everything, right? But in reality, maybe it's just a poor choice of the material for that clinical situation. Or maybe we misused the material, right? Maybe it was the right material, but we abused it. Maybe it was a preparation design and the ultimate restoration was too thin. And if the restoration breaks, we want to blame the material, but yet look at ourselves first and analyze, did I have enough space, right? So the technicians could abuse materials, of course. And so following strict protocols that manufacturers set up is critical. And they should collaborate with you if you're trying to do something and they realize it's maybe not the best choice of material, or they may need to inform you and suggest other options, because maybe you don't have the knowledge, but I always say it has to be clinically based decisions, and we should have knowledge, and that's where collaboration comes into play, and so you grow together, you learn together, and you can be more aware of how to use things correctly. So is the material the real issue? We've already stated we would argue no. It's not a material issue, it's something else.
So biologically, we have things that happen to teeth, caries, infection, disease, just a common complication of working in the environment that we work in. From a surgical standpoint, you can have healing complications, and some because of a non-compliant patient, some because patients just don't all heal the same. And again, I'm going to say that's a complication too. It's just, it comes with the territory that you're in.
If you look at what we're referring to as clinical technical problems, again, it's are we performing to, I'd love to use the word standard of care, but unfortunately standard of care doesn't truly exist in dentistry. But based on our knowledge and skill set, are we performing or are skills letting us down? So if our skills let us down and we should be doing better, maybe that's a failure, because I would then argue maybe we shouldn't be doing those procedures. Maybe we should be referring that out with someone that has more skill and understanding. So sure, we will decide when do I take risks and try something new, and obviously that's where you all try and take courses to learn more, to do more procedures, and we do our best to help you with all that, but it's still, you have to tread lightly on that and perform well.
Well, since we don't have any failures, that'll about do it for us. All right, so now let's actually show some cases. There's 3 things we have to keep in mind anytime we have a problem. First is you have to figure out what caused the problem, and I think that's something the dentists oftentimes lack. They just make it stronger without thinking about the bigger picture of what actually caused it to break or what caused the initial etiology. Second thing we need to do is we need to figure out how to manage it clinically so it doesn't happen again, right? Something happens once, patients will give you a pass. When it happens again, now they start to wonder about the quality of the dentist that they're seeing. Then the last thing, which is oftentimes the most challenging, is how do you manage the patient? How do you manage the patient from a psychological standpoint or a financial standpoint?
So we'll begin looking at structure. This patient presented to me a number of years ago, and that's one of the challenges of trying to go back and find failures and complications. You have to search the archives, right? And sometimes we haven't come up with all the images to share with you, because based on my timeline of treatment, I did a lot of my photography with 35 millimeter slides, and maybe some of those slides weren't scanned, so we'll do our best to share some history, but it would be relevant today even if this patient presented, because this patient has a vertical wear problem, vertical facets on the lower anterior teeth, exposed dentin, sclerotic dentin, and she has upper veneers on her teeth, and she says, I want my upper veneers done, but when you do that, I want you to veneer my lower teeth. So I go through the whole diagnosis, treatment planning, and my solution, treatment option, was to veneer the upper teeth and veneer some of the lower teeth, but crown a few of the teeth because of the loss of enamel, right? So I tried to inform her about that, and she said, no, if you want to crown my teeth, I'm going somewhere else. And I kind of talked to her again, and she says, no, if you crown my teeth, I'm going somewhere else. So it's my problem now, because I said, okay, I'll veneer your lower teeth, right? So I know I'm going to be bonding to sclerotic dentin. So if you look at a little bit of literature and look at failure rates of porcelain laminate veneers, this looks at a 12-year retrospective analysis of almost 600 veneers in 66 patients. 99% survival rate when the preparation contained enamel, 94% survival rate when there was enamel margins. And then the second follow-up article based on the same patient pool is there's 0% failure from debonding and microleakage when the preparation was confined to enamel. And so what was my case? Sclerotic dentin, which is the worst thing to bond to. And yet there's a 93% overall survival rate when according to the publishers, 80% of the prep was in enamel. So I accepted to do that, but now I'm at risk, right? So it's not the patient. The patient is truly at risk, but I'm the problem because I said yes. And after the 2 lower veneers fell off twice, I did that on my own time and my own dollar. I said to the patient, so are you ready to do the crowns on your 2 lower front teeth? But I did those lower 2 crowns, again, at no cost. But it was my problem. I had to admit that. So fortunately, everything else is working, but I was misusing the clinical procedure because I was bonding something I knew wouldn't be highly predictable. So veneers are highly successful. Here looking at feldspathic porcelain and glass ceramic veneers and looking at some differences. And at a period of 9 years, estimated overall survival rate was 89%. Estimated cumulative survival rate for the glass ceramic was higher than feldspathic, 94% relative to 87%. Why? Because we have a stronger material. And you look at the events. Again, lots of publication are looking at problems as we're defining them as events. I love that term. It's not a failure, it's not a complication, it's an event. So 2% debonding, 4% fracture chipping, 1% caries. Discoloration, again, was marginal leakage, and endodontic problems. I scratched my head on that one. Was it because a veneer was done? I can't imagine that. You look at clinical performance over 10 and 20 years. 10 years, almost 94%, 20 years, 83%. So now I believe we can hang our hat on doing porcelain laminate veneers, especially for bonding to enamel brim. But this is interesting, almost an 8 times greater risk of failure associated when there was existing parafunctional issues, right? So if I'm doing veneers and I have parafunctional issues and I choose to do it, right, I understand and I should inform the patient they're at higher risk of, quote, having a complication because now I've informed the patient. And the most interesting thing, again, is fracturing the porcelain. Almost 50% of the failures was fracturing. So when you look at what we do clinically, every one of us adjusts a crown or veneer or restoration when we put it in the mouth. And the literature is supporting the fact that by grinding on the ceramic at the time of insertion or after insertion, it creates flaws in that ceramic, and those flaws are a significant cause of chipping or fracturing of the ceramic later. So if you abuse the material in a clinical procedure and don't adjust it correctly with the right speed, the right diamonds, and then polish correctly, I would argue when that restoration fails, not if, when it fails, then you look at yourself first, and maybe it's what I did at that time of that adjustment. So this is a dentist I treated. I restored his 2 central incisors with lucite reinforced glass ceramic, so stronger than porcelain jacket crowns. And I don't remember the exact timeline, but and I don't remember if it was trauma, but anyway, the 2 centrals were fractured. He bonded one of the pieces back on, so that would be an appropriate way to manage a compromised situation. The other central had composite placed, and he got to the point where he wanted them replaced, so I replaced them. So sometimes I then ask myself the question, if it was trauma, clearly it was an accident, you have to deal with it. But did I set up a flaw in the ceramic by adjusting? Because maybe when I did that, I didn't know enough. Hopefully I did, but possibly I have to look at myself first. So when materials start failing, then you always want to go to a more invincible material, and we start looking at lithium disilicate. We all know that, and it's our primary choice to use today. And looking at this systematic review of single crowns and bridges, and that confuses the issue a bit, of course. Looking at the time frame of 1998 to 2013, they included 12 of the articles over their original search of over 2,000 articles. And I love this definition. It's the fracture of any part of the restoration that required the removal or remake of the restoration. That's a failure. Anything else is a compromise. A chip of the porcelain may be polished, still's in service, so that's fine. Okay, so let's look at this. Single crown, short term again, 1 to 5 years, 98% survival rates. Medium term, 5 to 10 years, almost 97%, although it says limited evidence, and this is a systematic review, trying to review everything, right? And then the bridges, 1 to 5 years, short term, 78%. And then 5 to 10 years, one study, 70%. So I would argue, would I ever use lithium disilicate to do a bridge? I'm not willing to take those risks, right? So yes, I do actually at times. So both Gregg and I, we do calculated risks. So when might I consider doing a lithium disilicate bridge, like a maxillary cantilever lateral off of a canine? Because I can manage occlusal forces. But honestly, if it would break at some point, I would redo it for free because I'm the one taking the risk. I'm doing it because I believe I can maybe get a higher aesthetic outcome. And the majority of those failures were on the posterior teeth. So when I treated this patient, we were using lucite reinforced glass ceramic. She had an eating disorder. She lost all of her enamel, so sclerotic dentin. We went through orthodontic intrusion of teeth, periodontal procedures for crown lengthening. I restored the teeth, had a great outcome. And 10 years later, she comes back and obviously fractured porcelain. So now I'm taking a material that must be bonded, and I'm bonding to sclerotic dentin. So at that time, maybe it was the best we could do. And I would argue the answer to that would be no, because I could always do metal, ceramic, and cement and maybe have better success. So it was really my fault. And so today I would do it in a stronger material, the lithium disilicate, design it with the appropriate thickness, and then you can achieve better, hopefully, long-term success because I have a more durable material.
So this patient comes to me for the 2 centrals, and they had palatal wear in the dentin. They're getting thin. So she doesn't look like she has any type of parafunctional habit. She has more of an erosive habit. So I prep minimally, right? About 1 millimeter reduction. And I'm going to use a lucite reinforced material like Bob had just mentioned. And I have decent dentin. I'm going to get a good bond to it. And I make the 2 centrals. Now, about 6 months later, she comes back in to get her teeth cleaned. I look at the palatal of her central, and you can get an idea. You can probably see it right there. There's a fracture. And why is there a fracture? Well, is it a material problem? No, it's a dentist problem. Because I didn't prep enough. I tried to be so conservative that I got thin, and I got thin in a functional zone on the restoration. So again, I think a lot of material problems are actually the fault of us as clinicians. So let me just show you this patient. He was in a traumatic accident. He avulsed his anterior teeth. That's his flipper that he comes in with. In fact, he had an implant on the central, and the implant actually fractured. But that's all due to trauma. Now you look at the ridge, and the ridge is all palatally positioned, and he doesn't want something removable. So I send him to Bobby Butler, periodontist that I work with, and he grafts the ridge, he brings everything out, and we place 3 implants. So I shape the soft tissue, and then I get ready to design the final restoration. Here it is. It's going to be a 4-unit bridge. It's a zirconia framework bridge, and those are zirconia custom abutments. And they just happen to all be zirconia. So I put it in, and we're both happy with the aesthetic result. The outcome looks nice. And probably within 3 weeks, he comes back in, and he's not happy. He chipped the porcelain. You know, these things happen. So I'll just fix it. I'll just bond it with composite. Now the reality is when you start having things that break, you got to figure out why it broke. If I restored all those teeth and they all broke, I probably put them in the patient's envelope of function. So I need to redesign the anterior relationship. But they all didn't break, 1 broke. So when you do a lot of anterior restorations and 1 fractures, it's an occlusal contact issue. Again, it's a dentist problem. So when he starts to come out somewhere into his protrusion, I probably missed the fact that all the force was localized into 1 spot on the ceramic. So I don't want to redo the entire restoration, so I aerobraid and I treat it and I bond it with composite. Save the day, it's a complication, let's move on. I repair it with composite that lasts roughly a month, and he chips it again. And so I said, let's try that again. And I bond it again, and it lasts about a month, and it chips. So now the patient is like, you know, I have a brand new bridge, and here you're trying to scurry to get things to fix. So this is cemented. It's a cemented bridge. I'm going to tap the bridge off, and I'll just remake it. All right? Now, I cemented it on with Neotemp, and it's zirconia framework, and it's got zirconia abutments, which is a nice, hard, smooth material, and so I take the little sliding hammer, little sliding tap mallet, right? You all know what that is? And
Hey, Gregg, they're laughing already at you.
And just a few little taps, and I tap it off. And I'm like, wow, I mean, that was amazingly easy. Until I actually looked at it after I tapped it off, and I snapped all 3 hexes off the implants. Okay. Failure? Yeah.
Obviously, this is painful to watch, right? This is really painful. But we're laughing.
But it's one of those where you say, at least it was me that did it. So what would I do differently, or what did I do differently? I'm not going to let that happen again. So I over-designed it. I went metal ceramic bridge, and at the time, the option was I did metal abutments. And that's a 9-year follow-up on the metal ceramic bridge with the metal abutments. Okay? What would I do today? With today's technology, I'd probably go to a cast UCLA PFM. So I can actually have the strength and the connection of the metal, but then I can have ceramic on the abutment, so I can stay in the all-ceramic realm on the restoration. So I could show you all sorts of these, right? Let me show you another one. You've probably seen this one before. Trauma, again, lost the teeth, not a functional issue. Graft the ridge, place 2 implants, all zirconia abutments. We're happy with the aesthetic result, even though we couldn't achieve the papillary heights, because his lip didn't go high enough to show you the junction where the pink meets up with his natural tissue. So this looks great. And I get a phone call 3 days after I put it in. It's loose. Right, cemented. Come on in. I'll take it off and I'll re-cement it. Now this, I know that I can break them, so I would be very careful, and I took it off. So he goes, no, I'll wait till Monday. He comes in Monday morning. It's not even been in the mouth a week, and he finished the job for me and broke everything. So now we're later on, and so here's new abutments. But again, there's always an evolution. These are custom metal ceramic abutments, but if I design the case today, do you see the margin on the distal, the central, the distal, the lateral? See how deep that is? I'd raise that up so I can actually make sure I can clean cement. Because I just might have created another problem by trapping cement. And so the next time we do this, you might see this case again.
So that leads us into the next category of function. And so this patient presents to me with the attitude of just hating dentists. He said, I never had a problem in my life until I went to a dentist to restore my posterior teeth. And ever since I restored the posterior teeth, I've had severe muscle discomfort. And he was living that way for 4+ years. And he had some of the dentistry done because the porcelain was chipping. He had a history of fracturing a metal connector on one of the bridges. And so you start looking at the situation, and here he's presenting to me, and I'm having move-in lateral movements, and I'm trying to look at tooth contacts. So as Gregg was saying, we still believe how teeth touch matter. You can see the attrition on the anterior teeth that he has a horizontal wear pattern. The question is, why is that occurring, right? And so our eyes are opening up as far as if there was an airway component. But when I treated this patient, I managed him with splint therapy to get him comfortable. Once he was comfortable, the plan was to do functional crown lengthening posteriorly so I could make longer connectors for the bridge. Because if I see metal failing like that, yes, it could have been an occlusal design, but I'm saying I'm not necessarily better than the next guy. I'm not going to do the same thing. I've got to change it. So we went through aesthetic and functional crown lengthening, fabricating the provisionals and making the transitional change, going through trial therapy, testing this out. In trial therapy, I don't use occlusal splints. The patient's comfortable, loves me at this point. It was also interesting dealing from an aesthetic perspective. He actually was traveling in from Europe. He was the best friend of my best referring patient from Los Angeles. And so that's why he was making the effort to see me. And so things are working out really well, and go to the final restorations. This is 24 hours after I inserted the final restorations. We're 12 years out. He's been totally comfortable. I think I'm going to have a chance to see him in a couple of weeks. He's coming in for a wedding of one of his relatives, so hopefully I have a chance to see him. But it's working well because I designed the occlusion to withstand the occlusal forces to allow him to move through his movement patterns, and in particular, work on his anterior teeth. Of course, I also provide the patient something to protect the teeth if he has a habit of doing that, and that's the Occlusal Guard. One thing I didn't truly appreciate when I was treating him, again, he was a super guy, but yet very stressed because of his initial presentation of discomfort. And as I'm treating him, here in Newport Beach, my office is right on the water, and there was a broker for yachts right below me. And I'd be treating him, and I'd be in the lab doing something, and he'd be without any provisionals or anything, just with prep teeth. And I'd see him down on a boat talking to a guy. And so he did that a couple times, and I said, "Bye, are you interested in a boat?" And he said, yeah, I've got to buy a boat. You like boats? Yeah, I have a 55-footer, but I need a bigger boat. And so the next day he's down there again, runs up, and I said, "You're really serious about that?" Yeah. I just bought a $5 million boat. And I'm saying, darn, I didn't charge enough in this case.
All right, we've got a lot of failures, so we're going to have to
move a little quicker.
but we want to make sure you see them
Wait
all.
a minute. You have a lot more failures to show, or what?
All right, let me back up here. This is this is the first rehab I did when I came into practice with Frank and Bob. So now we're talking 1998. So he's been restored. He's going to lose some lower anteriors. I restore him. Here's the rehab. Right? Everything's good. And then he breaks a cast metal joint on a bridge. Snaps the joint. Right? And he didn't snap it during the nighttime. He snapped it during the day. So all of a sudden, that happened, but it happened at 8 years. So is it a failure? No, it's just a common occurrence that can happen if you have somebody who I would say is a high-risk patient. It's not over. Then he snapped a 3-unit bridge in the anterior, and it's not a high-risk tooth. It's not an endodontically treated tooth, and it's not an over-prepped tooth. So when did this occur? Well, this occurred at 12 years. And so I look at that and go, this is just a common occurrence, and if I can see that from the beginning, I can set the expectation for the patient.
So if we look at metal ceramics as our gold standard, you look at 97% survival rates at 7 years and more. Anterior crowns, 12 to 25 years, 92% survival rate. Again, it's hard to beat that, but most clinicians are trying to get away from metal because we believe there's something better. Here, looking at, again, success rates at 18 to 23 years, 80% are unchanged, 3% were removed. Survival rates for single crowns up to 25 years. So the first 10 years, 97%, 25 years, 85%. What's interesting, looking at the failures, the majority of them, almost 75%, were biologic, meaning maybe secondary Ks and so forth. And then, of course, fracturing comes into play. And interesting, aesthetics is a small factor. And we're thinking about moving away from metal ceramics for aesthetic reasons. So patient satisfaction, looking at metal ceramics and zirconia, it's essentially the same, almost 90% and 93% patient satisfaction. So with the right technician managing the material, metal ceramic can still work. So if you look at ceramic fused to zirconia, this is interesting to me because 10-year survival rate of fixed partial dentures due to technical or biologic complications, 67%. Framework fractures, so the survival rate was about 91%. And then chipping and fracturing of ceramic, I'm sure you have experience with that, even on single restorations, but times have changed because of improvement of materials and techniques. But 32%, this is reporting with a significant correlation to the length span of the bridge. Okay, so if it's a 4 to 5 unit bridge, there's a 5 times more likely probability of having chipping compared to a 3-unit bridge, right? So these are red flags for me going up because zirconia frameworks can flex, and if that flexes, the veneering porcelain will fracture. So I have not done a full contour zirconia bridge. This is Ricardo's case. I mean, beautifully done, aesthetically pleasing, fits beautifully into the patient against natural dentition, and yet you look at the outcome and you see a significant, I would argue, catastrophic failure. And Ricardo will show how he managed this, but it is a true failure, right? You may try and repair it, but, you know, as Gregg was saying, if it's that significant, patients may want to address that a little bit more importantly, significantly. And then the next patient I treated is a young individual presenting with the concern of aesthetics. He doesn't like the appearance of his teeth. His parents didn't like the aesthetics of his teeth. And yet, when I look at him today, I have a totally different appreciation than I did when I first saw him. Like we talk about incisal edge display and repose and smile, and maybe we should talk about tongue display. So if I look at that tongue sticking out, in every image I go back to and look at, the tongue is protruding forward. So we begin to think about airway. That wasn't on my radar when I treated him the first time. Okay, so I just show different intraoral views. Look at the teeth slightly parted, the tongue is kind of pushing in between. And I have him go in different movements, and I see the wear pattern. And he also says to me that I just love to play on these teeth. I love to do this. I just spend every day there, and he stands there in front of me and just grinding away. He loves to do this. He's a high-risk patient because with his own life, he's high risk. At the Wedge in Newport Beach, you know, when the waves are huge and stuff, you get on the little boards and you get on the wedge and you're slammed into the sand, and he'd come in with dislocated shoulder. The next time, he said one of his friends was broke his back and was in a wheelchair, and then he was excited to go back, right? So then I start thinking, well, is it his high-risk habits as well? So when I go through and manage him, I have to design the occlusion appropriately because I'm now first thinking, trying to allow him to play on this lateral horizontal movement. So I get him into provisionals in 1 month, he breaks the provisional. I rarely see fracturing a provisional, so a big red flag goes up to me. I repair it a month later. Now I get a shear of the provisional. So now I'm thinking about shortening the teeth, managing the occlusal plane, and I finished the case, and it worked out aesthetically for him and functionally, and it worked out functionally right for a while. So here shows my follow-up photos, and things are looking good. It's sliding around nicely. He's loving it. I make the Occlusal Guard to protect the teeth, and 4 years later, both canines, they're sheared off. The veneer ceramic sheared off. At this time, it was lucite reinforced glass ceramic, but veneered for aesthetics, so the weak link was the ceramics. So you see the central is fractured, the upper and lower. So again, now I'm saying to him, because this is now 5 or so years ago, 6 years ago, got to know Jeff Rouse a little bit more about airway, and now airway's on my radar at that time, but still didn't know enough. And I started talking to the patient, and when I get into that topic, he says, yeah, my parents almost kicked me out of the house because I snore so bad. My roommates, leave. I can't get a roommate because I snore so bad. And I've had a sleep study, and they tell me I need a CPAP, and there's no way I'm doing that, right? And so I try and now talk to them about other things that can be done. No interest, right? So what do? Try and use a more durable material the next time around. And so using the lithium disilicate, and when designing the lithium disilicate, I'm going to take the monolithic part of it to the incisal edge and just create a little bit of a cutback for a facial enamel aesthetic overlay. So that's accomplished, and we get, I'll say, a pretty outcome. And it's working for him, and I will knock on wood when I say that, because he's a high-risk patient but doesn't comply with really what should be done, and that's really addressing his airway issue, which then I might be able to manage the occlusion better.
So biologically, we can have problems, and biologic problems often be quite catastrophic. This is a patient that I'm working on with Jim. So Jim does surgery. He's going to do some guided bone regeneration. He's going to put his membrane in. He's going to use bone graft, and he's going to get primary closure and suture everything up. Now, what do you need to do when you do these procedures? Whatever goes on top, you need to give it room. You need to give this material room to swell, and it's going to swell. So similar type of patient up on top, similar technique, different patient. So the goal then would be whatever's on top, whatever pontics you have, in this case it's on an arch wire, you need to really drastically reduce them so they don't impinge upon the swelling tissue. Well, unfortunately, that didn't happen on this case. Jim normally says, I usually do that myself. But because of the busyness of the day, I left a note for the orthodontist to do it, and evidently the note didn't hit. And so all of a sudden the patient comes back with a post-op complication. There's the sutures, there's what it looks like when it's returned, and there's now the membrane that he has to basically take all the way apart. In fact, if you look at it as it's healed up and you compare that ridge to the ridge before, it's actually worse off now, right? So there can be technical things that occur, there can also just be healing things that occur.
Yeah, and it may be patient-based. The patient may not comply with the instruction post-healing. So this patient underwent root coverage procedures, and this is about 5 days afterwards, and you can see that there is infection. There's the graft being exposed, and how to manage that is really critical. So initially you may panic because you look at the height of the Phrygian margin and you think maybe the recession is going to get worse. But it's just managing it. But the critical part of it is being patient, managing it correctly, and getting the patient to, before treatment, truly understand compliance is the key. So you still can, I'll say, save the case. On the previous case, that it would be a whole nother situation, right? So that gives us to a little bit more complicated situation. So I'm going to show the complication that I've found from a previously treating dentist, and now how to manage it, but even my outcome will be compromised because of the way we approached it. So veneers were done on the upper anterior teeth with a single tooth implant, and there was challenges with the implant. I believe it had to be taken out and a second implant placed. They managed it with soft tissue. The previous dentist was trying to manage contours, but now I look at the significant defect in the implant site, so it's deficient in form, a biologic problem. And so when I disassemble this and look at it, you can see this significant cleft in the tissue. Remove the abutment, and it's really rough and irregular, so I manage it by polishing it. So I'm using that as an initial stage to make some provisionals, because the patient also wants to replace the veneers, but we need to do crown lengthening procedures because the teeth were short and fat. So that's where we're heading. But I look at the tissue everywhere, and it's very red and inflamed. And as I start disassembling the previous veneers, and I'll just walk through various clinical images, and what am I finding? I'm finding 1 millimeter at almost 2 millimeters thick resin cement that was still remaining under the tissue. So I'm taking out huge chunks of composite. So I prepped the ceramic off, and now I'm fishing out the resin cement. So making the provisionals for sure was difficult. You know, I strive to get good margins, and it's always humbling to look at surgery, the openings you see, because you're trying to manage this in a bloody field. So the patient's going to go through procedures to crown lengthen the veneered teeth and do a tunnel technique and an allograft over the implant site. So the decision now is to take a minimally invasive approach to improve the biology around the implant, knowing that there could be a better approach of doing a lateral pedicle from the palate, maybe burying the implant and getting more soft tissue, but it was a more conservative approach, just trying to get more healthy tissue. So the surgical procedures are performed, and you go pre-op 4 weeks, healing really nicely. It's like, wow, if it heals like this, it's a real winner. 9 months, it's looking pretty stable. The tissue's moving a little bit apically. And so pre-surgical at 9 months, it's looking good. Now I get into the final restorative phase, and look at the distance between the prep on the central and the mesial, and on the mesial the lateral. It looks like I can put 2 centrals in there, right? So it's a big aesthetic challenge. So I'm going to do the new abutment. And the design of the abutment, I'm now trying to use materials that maybe today would do differently. So the tie base, I cut part of the tie base out. I use lithium disilicate to extend it down. Today, if I would do the case again, I would probably go to a UCLA type concept. We have good, healthy tissue at this point. Aesthetically, it's a compromise, right? So it's a compromised outcome, but yet...
We're not done.
Okay. Fortunately, it's not exposed in the appearance of his smile, so it works, and he loves the case, so it's biologically stable. What do you want to do?
Well, we could rifle through all the slides in 1 minute, but I think that's going to be counterproductive.
Okay. So what are you going to do?
So could we just advance to the second to last slide, please?
It's funny, we had so many failures, we couldn't show them all.
I know, it's amazing. And here we thought we were going to get done early. One more, please.
Wait, did I win? Did I have more than he did? because maybe he can show the rest of his. That's why he wants to advance. He doesn't want to show them.
All right, I want to make sure that we get to this very end, which is actually the most challenging aspect of a failure, right? What are you going to do with the patient? It's always funny when something breaks. If Bob did it and I'm restoring the patient now, it's not a problem. If Frank did it and it's not a problem. It's when you do it yourself and it fails that you have an issue, right? And the question is, how long ago did it fail? And how do you now recoup that if it's, let's say, less than 5 years? And we honestly went back and forth, and we don't have a take-home rule. Our take-home rule we follow emulates what Frank has always done. He goes, it depends on why it broke, right? Was it neglect, or was it just something that can happen? But it really comes down to is, do I like the patient or not, right? Because if I like the patient, I'll probably try to help them, and maybe I'll do it for free, and maybe I'll only charge the lab bill. But then it brings up the other aspect, which would be, do you really want to be working on an upset patient, right? Do you really want that negativity in the operatory? And sometimes I do it because I think it's going to ease the patient's mind. But that's a judgment call that you all have to make on your own on how you proceed and manage that. So we'll end with a little quote. And the quote I think is actually good. Success is the ability to go from one failure to another with no loss of enthusiasm. Failures happen, complications happen. I think the champagne helps with the enthusiasm.
Absolutely.
So, thank you very much.
Thank you so much.